We're really excited to be with you this evening to share, obviously, news and knowledge with regards to reimbursement changes that are planned for 2026. First off, I'd like to talk a little bit about LifeNet Health, if I may. LifeNet Health, we're out of Virginia Beach, Virginia. We've been around for 40 plus years. We're the largest and most trusted organ provider, as well as tissues and cells. We have the longest accreditation of the AATB. And we're actually a not-for-profit, and we're really focusing on safety, quality, innovation, and service. We have a full portfolio of products ranging from a debridement tool in Sonic 1, a xenograph in Theragenesis, an amniotic called Matrion, a couple of decellularized allografts, Dermacell Porous and Dermacell AWM, and a living skin in TheraSkin. But I'm not here to talk around our products. I'm here to introduce Kathleen Schaum, who I've known for a number of years, and I'm sure many of you that are on the phone on the call this evening also know Kathleen. Kathleen has, believe it or not, has been in the space of reimbursement for over 50 years. Kathleen's recognized as the industry expert in wound care reimbursement. We're incredibly blessed to have Kathleen here on the call. I first worked with Kathleen back in Johnson & Johnson medical days, and Kathleen worked with Smith & Nephew as well as HealthPoint as well. So Kathleen, we're incredibly lucky to have you here this evening. We've got a great number of attendees that are planning on learning from you. So Kathleen, over to you, if I may, please.
Well, thank you very much. Thank you to LifeNet Health, and thank you to all the attendees. When you're a reimbursement person, you are always wanting to share information with your colleagues and with the professionals so that they can manage their business correctly. This year is an interesting year because the CTPs happen to have a potential of many changes. So therefore, we are going to talk about the Medicare 2026 CTP reimbursement is changing. We're going to talk about impacts, insights, and steps that you should consider to take now, because the change is coming, and now is the time to prepare. And the next slide, of course, has on it the fact that I am the president of my own consulting company and love sharing information with all of you. And my phone number and my email are on that particular slide. And if we move to the next slide, which is a disclaimer slide, those of you who have heard me speak before know that we must tell you that the information that we are providing on coding and Medicare payment and coverage is really provided as a courtesy. But we cannot guarantee that you will actually receive payment. The information I'm sharing with you was current as of August 22nd when we prepared the slides. And of course, it's subject to change, and particularly subject to change because what we're going to be talking about today is things that are proposed, but they have not all been finalized. And then that makes the onus on you for you to stay on top of the exact coding, payment system, and coverage policies and regulations from the various payers of your patients. And on the next slide, I remind you that we will be talking about CPT, standing for current procedural terminology, and that is a trademark of the American Medical Association. And if we move to the next slide, reimbursement is always filled with acronyms. And many of these acronyms you already know, but I am bringing to your attention just a few of them. Number one, now I will say CTP, which is different than the CPT codes from the AMA, and CTP is the cellular and/or tissue-based products for skin wounds. The old term was skin substitutes. Reminding you that HCPC HCPCs stands for the Healthcare Procedure Coding System, which is the coding system that gives the A and the Q codes to the. Then I'll bring your attention to HOPPS, HOPPS. That is the payment system for the hospital outpatient department, and it is called HOPPS, Hospital Outpatient Prospective Payment System. And the one for the physicians, the payment system for the physicians, is MPFS, Medicare Physician Fee Schedule. And of course, the outpatient departments that are owned by the hospital are called provider-based departments, better known as PBDs. And then, of course, the QHPs are the qualified healthcare professionals, meaning the nurse practitioners, the PAs, etc. And then the last one will be a new term for you, WISER, which we will talk about, but it stands for Wasteful and Inappropriate Service Reduction. And we will talk a lot more about that in just a few minutes. So the objectives for today. I could probably talk on this topic for about 8 hours. So I had to narrow this down to what can we get done and do a good, very succinct job with in a 45 minute period of time. And so the objectives are 5 of them. Number 1, I'm going to identify the CTP application code change that may occur in the provider-based departments in 2026. Number 2, we're going to recognize that all the stakeholders use the same HCPC codes for the CTPs. 3, we're going to review the status of the Medicare coverage policies for the CTPs. 4, we're going to introduce the WISER prior authorization model that includes the CTPs. And 5, we're then going to identify some implementation steps that you should consider to follow if the proposed 2026 MPFS and HOPPS rules are enacted exactly as they are written. So that's a lot to get done, but we will move swiftly and succinctly. So the first thing we want to ask ourselves is, who's going to be affected by all of these proposed changes for the CTPs for 2026? And it's mostly going to be the professionals and the providers who purchase the CTPs, such as the physicians and other qualified healthcare professionals, as well as the provider-based departments. So those will be the persons and that are affected the most by this. The next slide says then, well, what components of the reimbursement may change? And you know, reimbursement's made of 3 things: coding, coverage, and payment. And how could it possibly be that in 2026, we have the potential for codes, coverage, and payment to change in some way, shape, or form for the CTPs? So let's talk about that. And we will begin with the next slide, which is we will first start with coding. On the next slide says that some codes for the application of the CTPs may change effective January 1, 2026. So let's just think about, we're talking now about the application of the product. So let's talk. We know that currently physicians and QHPs use all these codes that are on this slide for the application of CTPs. It doesn't matter what brand they are, whatever, these codes are always used by the physicians and the qualified healthcare professionals. But for the PBDs, these codes are only used if the product that is being applied happens to fall in the high-cost ambulatory payment classification group. And so we know they're in pairs. The 15271 and 272 are for the trunk, arms, and legs that is less than 25 square centimeters, and then each 25 square centimeters up to 99. And then the next pair, 15275 to 276, is for the smaller anatomic locations, including the feet. Now, if we look at the next slide, we will see that the codes look very much the same, only they begin with C. And those codes then are the ones that are used by the provider-based departments for the products that fall into the low-cost APC groups. So that's really important because I'm going to be talking about what we're going to have to do with these particular codes before the end of the year. Now then let's talk about the next slide shows us if we are applying 100 square centimeters or more, then indeed the physicians and QHPs use the 15273, 274, 277, and 278. And the PBDs only use them to report the CTPs that are assigned to the high-cost APC groups. So there, you have to really keep in your mind how those codes are used, and you have to set your charge masters up correctly. And that's what's happening currently. All right. Now, let's take a look at what is going to happen for next year, or what is proposed to happen. Okay, so if the proposed HOPPS rule, which is the one for the provider-based departments, if that is enacted exactly as it's proposed, a very interesting thing's going to happen. The PBDs, the physicians, and the QHPs will all use the same application codes. It won't matter what whether the product was in a high cost or a low cost APC. No more will that matter. Everybody will use 15271 to 15278. Therefore, if this goes into effect, the provider-based departments are going to need to be sure to delete C5271 and C5278 from their electronic health records, from their charge description masters, their coding software, their billing software. Those codes will go away because we will not be distinguishing between high and low cost products. Now let's go to the next slide. And that we always need to also remember that I've just talked about the application codes, but these proposed rules do not change the product codes. So we know that some of the products are assigned HCPCS codes that begin with Q and some that begin with A. And it is very important that we report the exact correct code or that is assigned to the product, and they will still be assigned A codes and or Q codes. So that's kind of what's going on with coding. Now then, let's talk about coverage. This has been a hot topic, and I am not going to beat this dead horse to death, but it has been a hot topic for the last few years. And so I'm just going to give you an overview and remind you where we are at this moment. All right. We know we have three 3 Medicare administrative contractors who currently have active LCDs and LCAs. They are CGS administrators, First Coast Service Options, and Novitas Solutions. Those 3 MACs have a very clear delineated LCD and LCA that give us the rules and makes it actually quite easy to follow their rules as long as we read the LCDs and we read the LCAs and we implement them into our medical decision making as well as our documentation. Now there's a total of 7 MACs, so that leaves 4 MACs that currently do not have an active LCD or LCA, which means that they are paying this based on your documented medical necessity. That makes the job much more difficult for the providers in these 4 MACs. So if National Government Services, Noridian Administrative Services, Palmetto GBA, or WPS is your MAC, then the bar is higher for you to prove medical necessity because there's no documented LCD for CTPs. However, I'm reminding you, I cannot emphasize this enough, that they do have wound care LCDs. They have them for wound care. They have them for debridement. They have them for surgical dressings, negative pressure, HBO. And remember, we're in the wound care business. We're not in the CTP business. So even though they don't have an LCD for CTPs, all of those other LCDs still count. And so if you want to understand and be sure that you are getting everything you need into your medical decision making and into your documentation, I emphasize to you to look at those existing LCDs and be sure that you tighten up your documentation. Now, we also know that all 7 of the MACs got together and they reviewed, they published evidence for products and they reviewed the wording of the LCDs and they said, we're going to make the LCDs the same across the United States. And those were put into place as far as being future effective, and then that was delayed, and now the date for them to possibly go into effect is January 1. And if they become active on January 1, then the LCDs for CGS, First Coast, and Novitas would be overridden by these LCDs, and that means there would be the same LCDs throughout the country. Those LCDs then make it very, very easy for you to know. It's like a roadmap. Okay, here's what I need to have in my medical decision making. Here's what I have to have in my documentation, etc. So the people who are under the 4 MACs that don't have an LCD, if indeed we get the across the board LCDs come January, everyone will be following the same rules. So you have to keep your eyes and ears open for that. Now, let's say, though, for some reason, though they get postponed again, then we stay exactly where we are. And that is, there's 3 MACs that will have printed LCDs and 4 MACs will not have them. And that makes the onus much more difficult for those of you who are in the jurisdictions of those 4 MACs. Now, let's look at one other new coverage thing that is happening. effective January 1, and it will run through December 31 of the year 2031, a prior authorization model will go into effect. This is not proposed. This is happening. And that it will be prior authorization for a laundry list of procedures. And one of the set of procedures that affects us in this space is for the application of the CTPs. So this will apply to the physicians, the qualified healthcare professionals, and the provider-based departments who apply CTPs in six states. Now, what they're going to do is they are going to be using a vendors, and they're calling these vendors model participants. And these vendors are being selected on the basis of they have a huge amount of experience in reviewing medical records via artificial intelligence and machine learning, but they must also have every single claim or prior authorization request must be reviewed by a human person who is qualified. So this should ensure timely and appropriate Medicare payment for the CTPs. Now, what are the 6 states? They are actually in 4 of the MACs. 3 of the MACs have printed LCDs and active LCDs. 1 currently does not. So the 3 MACs that have the active LCDs are CGS, and that would include then the state of Ohio, and then Novitas in Oklahoma and Texas, and Novitas in New Jersey. And then the MAC that does not have an active LCD is Noridian Healthcare Solutions, and that will be the states of Arizona and Washington. So if you are in those states, you will be in a prior authorization program come January 1. And let's look at the next slide to see what your options are going to be. Your option is going to be one of 3 things. You're going to be able to submit a prior authorization request directly to these model participants. That's the vendor who is going to be doing the prior authorizations. So you can submit directly to them, or you can submit to your MAC. You can ask your MAC for prior authorization, and the MAC will still shuttle that request over to the model participant. And the third is you don't submit a prior authorization request at all. You just submit your claims, but guess what? Then your claims are going to be subject to medical review. And that is going to hold them up more than if they went through the process that is set up for the prior authorization. So in the big red box on the slide, I have a real important message to you. And that is, if you manage wounds and ulcers in one of the 6 WISER model states, now is the time for you to be discussing which one of these options you are going to follow whenever you are going to apply CTPs. You're going to have to pick one, and so you should be talking about it in your organization, deciding exactly which one of the options you're going to follow. But and you will be then in a prior authorization mode until the year of 2031 is over. Now then, let's move on to the third part, and that is Medicare payment. Oh my goodness. Could any more things possibly be changing? Well, let's think about how CTPs and the application of CTPs is paid right now. All right. If you are a physician or QHP and you purchase your own products, then indeed you get paid for the application of the product and you get paid for the product, whether it's an A code or a Q code. All right. So you get paid for the procedure and you get paid for the product. Now, if you're a provider-based department, that's not true. Okay, if you're a provider-based department, the provider-based department is paid for the procedure and the product is packaged inside of it. So the provider-based department gets one payment, and the only difference is if the product is labeled in or assigned to the high-cost APC groups, then you are getting paid for the 15271 to 278 rate. And if you have a product that you're using assigned to the low cost group, then you would be getting paid for the rate for the 15271 to 278. So you can see there's two very different things that going on now and have been going on for the last few years. All right, let's look at the next slide and say to ourselves, well, then what is the problem? Well, this is a problem. Exactly what problem is it? Well, first of all, for the physicians and QHPs, we often have products that are selected based on how much they pay rather than based on the evidence and the medical necessity of a particular product for a particular patient. And then that often causes the patients to have an unnecessary large copays. Now, the problem on the provider-based side, the provider-based department side, is even a little messier in that whenever you have the product packaged inside the application code, and you have an ulcer that is greater than 25 square centimeters up to 99 square centimeters, you get the same amount of money for a 25 square centimeter wound as you would if it was 75 square centimeters. So you don't get any more money to buy that extra product, which is why the outpatient departments so often cannot afford to take care of larger wounds. So that is one big problem that the provider-based departments have had. And then the other problem that just has made me crazy just for years now is that if we have a 100 square centimeter or greater ulcer on the leg, we get a nice payment for the application and to include money enough usually to pay for 100 square centimeters of product. However, if we have the same 100 square centimeter ulcer on the foot, we don't get the same amount of money. And that means that the outpatient departments, the provider-based departments, have a very difficult time to take care of those large diabetic foot ulcers because there has been not enough money in that code for them to get paid for that. So let's look at some of the good news that is in the proposed rules. First, let's look at the physician fee schedule. All right, the physician fee schedule is still going to pay separately for the procedure as long as it's medically necessary and reported with the correct codes, the 15271 to 278. And it will continue to pay separately for the product. However, it is going to pay the same amount of money for no matter what the brand is. And that would be, it's proposed to be $125.38 per square centimeter. And they base that on, it's the highest average of the 3 FDA categories of the current CTPs. So say that again, in the physicians, they would still get paid separately for the procedure and the product. But for the product, no matter what the brand, it would be paid at $125.38 per square centimeter. Let's take a look then at the next slide to see what these rates look like for the application. On this slide, I show you in the first column is what the rates were. Non-facility means office, all right, or office or home. All right, and you can see, let's, for 15271, we'll use that as an example. For 2025, the rate was 148.47. And if you go over to the column, and the 1, 2, 3, fourth column from the left, it is the rate for the proposed rate for 2026 is $158.08. So you can see there is an increase. But in the physician fee schedule, it's also proposing to reduce all the rates for physicians who do work in facilities. And this is a perfect example to show you that. You can see that for in 2025, if the physician did 15271 in the outpatient department, the rate was 81.51. That's the national average rate. But in 2026, it would be $74.86. So that is the effect of what's going on for the application codes. And as I said, then the product is going to always be paid, if this goes through, one rate, no matter what the brand is. Next, go to the next slide, and you will see the great news for the provider-based departments. I am so excited about this. And this is proposed, and I just hope that it goes through. The payment for the CTPs, for the products, will no longer be packaged into the payment for the application. That is just so exciting to me, because that has caused us so many problems ever since that has been implemented. So that's great. In addition, just like the physicians, because if they're going to not package the product, that means then that the outpatient department would get paid separate for the product. And yes, that would happen. And if they're paid separate for the product, they would be paid at the same rate as the physicians would be in the physician office, the $125.38 per square centimeter. Now, what's really cool about that, if you work in a provider-based department, you think about that. That would allow you to afford to take care of the larger wounds now, because you would get paid for the application. And then if the wound was larger, you're going to get paid per square centimeter for the product. So that is really good news, that you won't be stuck only taking care of smaller wounds. Now, because all of the products are going to be paid the same, they will no longer be divided into high-cost products and low-cost products. And therefore, we won't have to delineate high-cost versus low-cost. And that's why I'm telling you, if this goes through, you will need to remove C5271 to C5278 from your system. All right. And then the other thing that just makes me so happy, I just would love to cheer about this. And that is that finally they're going to pay for the ulcer that is 100 square centimeters or greater on the foot at the exact same rate that they pay for it on the leg. So now, if you have a 100 square centimeter ulcer on the foot, you will be able to afford to buy the product because it's going to be paid for. Is the application. This is going to be the rates are the same, and then you're going to be paid for the square centimeters of the product. And so to show you that, let's take a look at the next slide. And you know that all these codes in the outpatient department are actually assigned to what's called an ambulatory payment classification group. And so look at 15271. All right, that's the application for the leg. And you can see the APC group for 2025 was 5054, and its rate was $1,829. Okay, because the product was inside of it. Now we're peeling the product and the application apart. So we move 15271 to a lower paying APC group, but still quite nice. All right. And so it's 5053. And so the outpatient department, the national average rate would be 746.61. But in addition to that, they would get paid the $125 and whatever that is, 30 some cents for the product, all right, per square centimeter. And so where the real problem was, as I told you before, it used to make me crazy, was because in the larger, for the larger wounds, the larger ulcers, look at 2025 for 15273. That was the application on the leg. Now, if you had the same 100 square centimeters on the foot, you can see 15277, how it was so much lower. That's why you couldn't afford to put it on the foot. But finally, in this year, if this goes through, they're both in APC group 5054. So now you would get $2,137 for the work to apply it on the leg or the foot, no matter, as long as it's 100 square centimeters, and you would get paid for the product. So for the provider-based departments, I hope that you're cheering about this because I think this is great news. It's something that we have wanted for a long time. All right, let's take a look at the one other piece of this. This rate, this $125 per square centimeter, is the first start of what CMS intends to do, but that, you have to start somewhere. So this year, all the brands are going to get paid the same amount per square centimeter. And if this goes through, in the following year, they're going to have 4 groups of products. One would be and they were going to be grouped by the way they came through the FDA. So the first group would be a biologics license application. And by the way, at this moment, we do not have any products, CTPs, that have come through as a BLA. But if we do, they would be paid the average sales price plus 6%. And that would be the only category that would be paid that way. The other categories would be the pre-market approval, or PMA, the 510K products, and the self-determined 361 HCTPs. So we expect in 2027 that they would be grouped into groups, and that there would be a possible different rate for each of the groups. So it's very, very important for you to report the correct codes with the correct charges in this year, because that data is going to start to be used to affect how these groups are paid in the future. So I actually did a little homework on this. Medicare said, and we're also proposing to get you used to this for the outpatient department, we're going to have 3 APC groups. we're going to have APC 6000, and all the products that are a PMA are going to be grouped into that group. And then we're going to have the APC 6001, and all the 510K products are there. And then I'll show you the next slide in a minute. Now, what I did is I said to myself, okay, we know that the rate that these are going to be paid is 125 and change. So I went and I looked at the ASPs that are printed and published for the products. And if indeed the product has an ASP below the 125, it's in green on the slides. If there's no ASP yet reported for that product, it's in black. And if the ASP has a higher rate, which means, yeah, it may have a published higher rate, but they're only going to get 125, it's in red. So, and I did that for the sampling of products that would fall into these two APC groups. And now if you take a look at the next slide, the third group was going to be the 361 products. And as you can, I did the same thing with them. So black means that there's no ASP yet printed. Green means that currently the pricing would be below the 125, and the red means current pricing would be above the 125. So those are things that you have to think about, because if something costs you more than you're going to get paid, then you have to discuss that with the manufacturer, and or you have to switch product, or you have to do something, only because everybody's going to get, if this goes through, the same rate. So that being said, I've given you a lot of information, and I really wanted to give you a few tips before we close. All right, this is things that you should think about doing, because you can't wait to start making these decisions come November. You don't have enough time to put all this in place. So at least you have to think through it and say, okay, if this happens, then I have to do this, this, and this, and I have to have something in place to do it. So let's talk about something that affects all of you, the physicians, the QHPs, and the PBDs. You have to verify that you are reporting the correct HCPCS codes in your systems, okay? Because now those codes are very important, and particularly in the PBDs, because you guys haven't always been real careful about that, because you said, oh, they're all packaged, it doesn't matter. But it does matter now. So be sure you're using the right HCPCS codes for the right products. Second is, because all of these coverage audits are going on, we need to be really, really sure that we're doing everything correctly. So you should be conducting audits at least quarterly, internal audits, to be sure you will pass a audit if it happens to you. And to me, it's not a matter of if, it's a matter of when. All right. Then the other thing about coverage is you have to look at those future effective LCDs. If they go into effect in January, what things will you have to put in place, like the KX modifiers, like the number of keeping track of the number of applications, being sure that you are using covered products versus non-covered products. Those are things you have to think about now, so that if that goes into effect, you are ready and you know what you have to do in your system. You also, of course, need to review you're being paid, or what you're paid, rather, not paid, what you're charged for a CTP on the formulary you use, because you're not going to get paid any more than $125.38 per square centimeter. And therefore, you also need to think about adjusting your charges in your system when that's necessary. Now, we are in a comment period for both the OPPS and the MPFS. We're still in the comment period. And so you have a couple of weeks. If indeed you want to make any comments to Medicare about these proposed rules, this would be the time for you to do it. The next slide reminds you, those of you who are in the 6 states that are going to go into the WISER model, this is not proposed, this is happening. So it is extremely important for you to decide which option you're going to take. And then you need to watch very carefully for the model participant who is assigned to your jurisdiction. And they will most likely be pushing out information and communication to you on exactly how you will handle your prior authorizations for CTPs with that. And the next slide talks about the provider-based departments, all right? And reminding you that if this goes through, you will be deleting C5271 to C5278. You will refine your charges for 15271 to 278 because they will no longer have the products in them. And you will be sure then you're charging correctly for your products. And be very, very careful because you need to refine your charges for the diabetic foot ulcer code 15271 for the larger, because many of you have been charging a smaller amount for that because you knew you got paid a smaller amount. And now you have the opportunity to get paid exactly the same as you would for the leg. So I've given you a lot of information today. I hope that it's been helpful to you. It's a very, very important time for you to wrap your arms and your head around how you will implement these changes if they all go into effect. And I thank you for allowing me to share this information with you. And I hope that you will take very, very seriously how you're going to implement it. And Andrew, I'm ready for questions.
Hey, Kathy, first off, thank you so much. Just love your passion for your space. We have a number of questions, but I'm also conscious of time to make sure everybody gets out of here. So I'm going to do my best to rattle through those questions, Kathy. First question is, this question pertains to CMS's assignment of HCPCS codes to CTPs. In the past, CMS assigned HCPCS codes that begin with Q to all CTPs. Now CMS is assigning HCPCS codes to new HCTPs and is assigning HCPCS codes that begin with an A to all other new HCTPs. That means older non-HCTPs have HCPCS codes and new non-HCTPs have A codes. It's a confusing question for me. This is so confusing to professionals and coders. Do you think that CMS will ever correct this inconsistent code assignment? Question 1, Kathy.
Okay. It's anybody's guess whether CMS will change the inconsistency. However, it doesn't matter as much now. If indeed they're going to charge the same for no matter what the brand, it won't really matter whether it's an A code or a Q code. But do they have the right? Yes, they could. One day we could wake up and find out that they're going to give all the products a Q code, or we could find out that they're going to give all the 510Ks and PMAs and BLAs an A code and the HCTPs a Q code. It could be anything, all right? But honestly, it doesn't matter. Just whatever product you're going to have on your formulary, just find out what the code is and be sure it gets put into your system.
Okay. Next question, Kathy, Kathleen, if I can, please. I work in a state that does not currently have an LCD and LCA pertinent to the CTPs. During a recent audit, It appeared that the auditors were following the future effective LCDs and LCAs when they reviewed my charts. I failed because my documentation did not include a plan of care and complete wound assessment at every encounter. I also did not address healing progress at every encounter. How can the auditors hold me accountable for an LCD and LCA that is not yet effective?
Well, that's a huge assumption that that's why you failed. All right. Because keep in mind what I said. Even if you don't have a printed LCD about CTPs, you are in the wound care business. And all of our MACs have LCDs about wound care, debridement, surgical dressings, etc. And they're very explicit about plans of care, complete assessments, showing progress from one encounter to the next. So clearly, just because you don't have an LCD, that doesn't that's the LCD for CTPs, that's true, except that you still have LCDs for wound care. And that's what everybody tends to forget. We are in the wound care business, and those guidelines for wound assessment, plans of care, progress, etc., have been there for years.
Kathy, a couple more questions have come in, if I can. I live in New Jersey. I don't myself, but the question comes from New Jersey. I live in New Jersey and must participate in the WISER prior authorization program. Can you please tell us about the process for requesting prior authorization?
Okay, remember it's going to be administered by a vendor called a model participant. Those model participants have not yet been announced for the 6 states, although they have already had to apply to be one. So I can't tell you the exact process you're going to use to submit everything to them. I told you your options. 1, you either do it directly to them. 2, to your MAC. 3, you don't ask for it and you send in your claim, and then you're going to be up for medical review. But the actual process, is there a form? Is there an electronic portal, whatever? That hasn't been announced. And when I was saying to you, keep your eye out for information and communication from the model participants, that's what I'm talking about. They will tell you the process. And that process, you want to get it right from the get-go, because you're going to be in that system until 2031. It's a long time, so get it right from the beginning.
Last couple of questions, Kathy, before we close out here. If the proposed HOPPS payment system goes into effect on January the 1st, do you think that the provider-based departments may shift their focus from using high-cost CTPs to using lower-cost CTPs?
Well, I'm not them. Okay, and you are asking my opinion, and in reimbursement, I don't like to give my opinion, but if you just think about it, the outpatient departments had the incentive to use high-cost products before. And of course, them and what was going on in the physician's office, et cetera, was starting to escalate and break the bank. All right, so now all the products are going to get paid the same amount of money. And so if you think about it, I would assume if you have some lower cost products that have great published evidence, then indeed, I would think that the provider-based departments, as they're thinking about their formularies, they may switch to a lower cost product as long as it had the published evidence.
Maybe consider Theraskin there, Kathy, just a plug. Last question. Actually, one just came in. I do apologize. When will we know the final payment regulations for CTPs?
Well, remember, we're talking about physician fee schedule, and we're talking about the provider-based department, the HOPPS schedule. And both of those will come out around Halloween. I call them the Halloween surprise. All right, because sometimes I'm giving out candy on my porch, reading the final rules. But last year they didn't. They gave us a break, and they didn't come out until the first week of November. But they have to come out in at least the first week of November because there's a 60-day implementation, and in order to implement on January 1, they have to come out in at least in the first week of November. So if we don't get them for our Halloween surprise, we'll probably get them in the very next day, few days after that.
Well, that's Kathy, let's hope you have a nice Halloween. Sincere thanks for taking the time here. I just, again, love your passion for your space, and we're excited for the next steps. You have a great evening. Take care. Thank you very much. Bye-bye.
Bye now.